Okay, Assalamualaikum and good morning. Thank you to the chairperson. So, I'm Amir from Anesthesia Hospital Melaka, and I'll be presenting on a talk on Pathophysiology of Fluid Imbalance. Sebenarnya topik ni agak luas, kompleks and besar, and the audience is very diverse, and I will try to make it simple. It may not be simple, but for those of you who want it to be complex, you can take the slides later lah, and you can see the evidence for yourself. So I don't have any complex of interest. So about sebulan lepas lah, my HOD told me that he wanted me to present on a topic for this course organized by the Plastic and Reconstructive Surgery Department. And my only guidance at that time was the slides given by my ex-head of service. By the end of this presentation, it may seem very complex, but my head of service slides was actually even more complex and even drier. So I'll try to dumb it down. And as I said before, if you want it to be complex, you can always ask questions and you can peruse the slides later. And there's not much time. In the original timetable, I was given only 45 minutes. So when we talk about fluid imbalance is a pretty complex concept because what is imbalance? It all depends on the scenario. Is it trauma? Is it in the perioperative period? Is it in the critically ill? Or is it in other scenarios like special scenarios like burns? And when we talk about imbalance, we have to think about the concept of whether it's related to the volume of the fluids that we give, and the type of the fluids that we give. Is it crystalloids, blood products, or colloids? And even when we talk about the nitty-gritty like crystalloids itself, the crystalloid composition, all this need to be taken into account. So, not for the audience, but I think it's just important to understand that to understand fluids, you have to understand the general concept that there are fluid compartments. And in general, what needs to be understood is that plasma itself, which is the fluid component of blood, is a very small component of a total body fluid. So let's say if you have the normal adult man, about 75 ml per kilo of blood, and a normal man, about 60% fluid in terms of the body weight, only 1/3 of it is actually in the extracellular compartment, and out of that, only about 1/5 to 1/4 is plasma. So whatever you give, in general, you are trying to treat the plasma component, but a lot of the fluid actually does not go there because, for example, if you give patient dextrose, so dextrose actually, because it's sugar. Basically, in the end, sugar goes into the cell and it becomes free water. And then when it becomes free water, it will just go to all the compartments, intracellular, interstitial, and the plasma. However, if you give patients crystalloids like normal saline or reverse lactate or Hartmann, then some of it remains in the extracellular fluid. But of course, like I mentioned just now, the majority of it is actually in the interstitial compartment. Whereas if you give colloids like albumin or gelafandin, so in theory, they are confined to the vascular compartment, but theory does not equal practice, because in basic physiology lah, if anybody is interested lah in the basic physiology, so when you talk about fluids, when they go into the endovascular compartment, so there is the classic Starling principle that describes how fluid go from the endovascular to the extravascular, into the interstitial. And this is based on the classic Starling principle, which is based on the difference in the hydrostatic pressure and the colloid oncotic pressure at the so-called arterial and venular ends. However, we have found that it's not so simple, and it's even much more complex, because as it turns out in biology, you have this intact glycocalyx layer which consists of proteins. And these proteins are and this layer and protein complex is actually the one that mediates transcellular flow of fluids, and it is the damaged glycocalyx that leads to dysfunctional transfer of fluids that you see in patients with edema, for example. So people thought in the past that in the arterial end, fluid goes out, and then the venous end, fluid goes in. But actually, with the revised model, any fluid that goes out will not return back unless they are returned by the lymphatic system. So, yeah, it's more complex than you think. So this slide basically just to highlight again the same concept of the glycocalyx layer, where you have an intact glycocalyx layer, then you have normal fluid function. However, once the glycocalyx layer is disrupted, then you get extravasation of your proteins, for example, albumin, and you get a pro-thrombotic state. But that's not the part of the topic today. So, another concept when talking about fluids. So you have this so-called concept of a stress and unstressed volume, especially when you talk about veins, the veins or the capacitance system. So in a normal physiology, you have this so-called unstressed volume, it does nothing, whereas the one that goes to the right side of the heart is the so-called functional stress volume. So when we give fluid bolus to a patient, what we're hoping is that we are going to fill up this unstressed volume compartment, and then everything will go to the stress volume. So you see, half filled, now it's filled, and then the stress volume will go into the right heart. Whereas if you give a patient like vasopressor, which is under recognized as a utility, where you will compress the volume compartments, and therefore the unstressed volume is pushed into the stress volume, and that stress volume goes into the right side of the heart. And you hope that by giving more volume to the right side of the heart, then you will give some positive output for the patient. Okay, complex kan? So let's go to our first concept, where you can have imbalance, which is trauma. And basically, to understand trauma, you need to go back to history. You need to go back to history. But whatever it is, the management of trauma needs to take into account the mechanism, the severity of the trauma, the organ systems involved, and the nearby surgical facilities. But whatever it is, the modern management of trauma is to prevent the lethal triad of trauma: acidosis, coagulopathy, and hypothermia. And if you develop this, then your patient will be at high risk of death. So it's very important to understand history. I will try to summarize the history. But basically, the beginnings of modern resuscitation probably started in around the time of the American Civil War in the 1860s. And then after that, further development in science and technology went into the identification of the major blood groups by the 1900s. And it was during the World War I era where people recognized that hypothermia was important. And one of the balance solutions, which is Ringer's lactate, was actually developed after World War I, which was designed to limit the administration of chloride into patients. So during the World War II, then you had the precursor of modern damage control resuscitation. So people thought about giving only minimal amount of fluids and then get them to a surgical facility. And it was during that time that further technologies like blood fractionation and then further testing in infectious disease in blood products were further developed. And then later on during the Vietnam War, things changed. So from initially, previously people were giving blood transfusions and then developed fluids. And then during the Vietnam War, people thought giving a lot of fluids was important for the trauma patients. And that was when people started to recognize that giving too much fluids to the trauma patient is probably not good. And that's when patients developed the so-called Danang Lang. So basically post-resuscitation ARDS. And then later on during the War on Terror, our medical practice turned back 360 degrees, made a full U-turn, and then we went back to limited resuscitation and blood. And this was during the War on Terror, the Iraq War, Afghanistan. So, and this led to the formalization of modern military medicine concepts as related to resuscitation. So, fluid imbalance can be related to the volume. I think nobody will argue that extreme hypovolemia is bad, But people probably don't recognize that hypovolemia, especially from massive crystalloids, is also just as bad because you will lead to hemodilution of your coagulation factors, and then you give poor fluids, you will develop hypothermia, and then you will get dilutional acidosis as well as from the dilution as well as from the hypothermia itself, and that will lead to the diesel triad. So fluid management in trauma is complex, but targets need to depend on the kind of trauma. Is it penetrating? Is it blunt trauma? Is it concomitant traumatic brain injury? But modern practice has led to the practice of permissive hypotension until they can get damage control surgery. And so here you can see this is an example of the US military guide for damage control resuscitation. And you can see here that in terms of their targets for resuscitation, they aim for generally low systolic blood pressure, about 100 only. Whereas if you have traumatic brain injury, then they target a higher systolic blood pressure. And you can see here that as regards to history, we have really moved from the past, transfusion, and then a whole lot of crystalloids, and then we've done a U-turn and gone back to blood. And in terms of the US military, they actually recommend whole blood in terms of their trauma resuscitation. And then only if you really don't have anything like that, then you give plasma or RBCs alone. But basically, they do not recommend crystalloids as the major fluid of choice. And of course, when it comes to preventing the table triad, they really emphasize the importance of warming the fluid so that you prevent hypothermia. So, severe trauma can lead to ARDS by itself, but respiratory failure can also result from excessive IV fluids. And therefore, there's a need to prevent the lethal triad of trauma. So, acidosis, coagulopathy, and hypothermia. And all of these three components can be related to the fluid that you give. So, if you are too restrictive, hypovolemia, and then if you give a lot of normal saline, you get acidosis. You get excessive saline, that itself will lead to acidosis. Too much crystalloids, dilutional coagulopathy, and then hypocalcemia, hypothermia, and then hypothermia from your core fluids. You didn't warm the patient. Shock in itself can cause hypothermia. So basically, what you're trying to prevent is all these three things from being present in the same patient, and that all of these three factors can be influenced by the fluids that you give. Okay, so that's one scenario where you can have imbalance in the trauma. And another important area where you can have imbalance is in the perioperative period, because you have a lot of fluid and electrolyte shifts. So in the period period, patients can be fasted, they can be given laxatives, and then in the intraoperative period, you have vessel dilatation from your anesthesia, you have ongoing blood losses, you have evaporation, especially with the open body cavity, and you have inflammation from the surgery itself. And then in the postoperative period, you have ongoing blood losses as well as inflammation. The general trend nowadays in surgery is that people are always talking about enhanced recovery after surgery, and there's an emphasis on having a neutral fluid balance. So for example, this is one of the ARDS guidelines on colon surgery, and they say that you should have a near zero fluid balance, and you should have a positive weight gain of no more than 2.5 kilo. So I hope that maybe one day we'll be able to weigh our patients in the OT, but this for now it's a guessing game in terms of how much fluids to give. So what's important to understand is that in the intra-op period, hypotension does not necessarily is caused by hypovolemia. I'm pretty sure that you've seen anesthetists give anesthesia and then suddenly the BP drop after induction. That's not from hypovolemia, that's from the anesthesia itself. However, hypotension and hypovolemia will, if it's uncorrected and uncompensated, will lead to reduced tissue perfusion and therefore cause direct harm. I think that's quite obvious. But what is not obvious is that if you give too much fluids, hypovolemia, you not only get respiratory complications, ironically, you also get renal complications and you get delayed functional recovery as well as increased mortality. So this is one of the studies done in 2019, a retrospective study, just looking at the post-op period of surgical patients in the ICU. So even though this study is not strictly intraoperative, it does show that post-operative weight gain kills. Whether you are talking about whether you're talking about the immediate post-op period, or the first 2 days, or the first 3 days, even the fact that you have a positive balance, fluid balance, will kill your patients more than even if you have a negative balance. And so this study does show that being overzealous with your fluid definitely causes harm. So even here, just having a small positive balance in terms of weight gain of just 5% is already associated with acute kidney injury. And we will see later why preventing acute kidney injury is important for the outcome of patients in general. Okay. However, it's not easy because especially with open cavity surgery, you have losses from blood loss, you have losses from evaporation, and the key is trying to find the ideal middle ground. I'm pretty sure no OT in Malaysia has an OT table that's able to weigh our patients, and everything is just a guessing game. So this really tried in 2018 tried to see whether having a restrictive versus a liberal fluid management will cause more harm. But if you can see here in their protocol, the restrictive fluid is 6.5 ml per kilo per hour, while the liberal is about 10. And they found that the restrictive group had higher rates of AKI, need for renal replacement therapy, as well as surgical site infections. However, there was no change in the overall mortality. However, if you look at this protocol, I'm pretty sure if you look into the GA forms of our patients in Malaysia, our so-called liberal group here is probably the minority, and majority of patients actually receive much more than 10 ml per kilo per hour. So I would say that that for me, this 10 ml per kilo per hour is my own personal restrictive group, and this 6.5 ml per kilo per hour is an extremely restrictive group. In fact, my personal practice with laparotomies is 500 ml per hour in adults without prejudice. This is to account for the evaporative losses. And if you, let's say you have a 50 kilo patient, so just the maintenance fluid is already 10 ml per kilo per hour, and that does not include ongoing losses. So in any study, you have to look into their protocol. That's the main takeaway. However, if you give a lot of fluids, people think only problem with the lung, nothing else happen. But actually, fluid overload does cause harm to the meaningful functional outcomes. For example, if you in laparotomies, so having a liberal fluid regimen can lead to delayed bowel recovery. In terms of for example, your gastric emptying time. You may think, oh, this is just a scientific data, nothing wrong with what you see in the real patient. But then again, having a liberal fluid management will lead to delay when the patients first pass platters, when they pass stool, when they eat, how long they stay in the hospital. All are affected just by the difference in the fluid regimen in the perioperative period. And even looking at complications like vomiting, confusion. So if of course this death is just one single patient, respiratory infection. All of these complications occur in the liberal group, while none of them occur in the restrictive group. And this should give you food for thought. So what about the kind of crystalloids? Normal saline or Hartmann or Ringer's lactate? Does it really make a difference? Sometimes you see people really argue, hey, we shouldn't give Hartmann. This patient potassium high. Does it make a difference? Nanti patient will become hyperkalemic because of Hartmann. But what about this study? Then this study was done in patients, renal transplant recipient surgeries. So they gave one group normal saline, they gave one group Hartmann. And what happened? So, where's the pH? So, the normal saline group had lower pH, more acidosis. The normal saline group had lower bicarbonate, and more patients in the normal saline group had hyperkalemia, ironically. while none of the patients in the Hartman group developed hyperkalemia. And you may be thinking, oh, how come giving Hartman is safer than normal saline? And the answer lies in the transcellular shift. It's because when you give normal saline, you're going to cause normal anion gap metabolic acidosis from hyperchloremia, and the chloride has to go somewhere. So the chloride goes into the cell, and the potassium that's in the cell will go out. And because of that, you are going to cause hyperkalemia, ironically, with a solution that does not contain potassium. So, looking into studies on the perioperative period, it's not easy because, like I mentioned in the previous study, what defines neutral or zero balance is difficult. And then, are you going to look just at your weight gain or the fluid balance? Because if you look at the laparotomy, obviously your fluid balance will be very high, and therefore you need to look at the weight gain. But weight gain is not so feasible in the non-study, in the non-university setting. And any study you want to look at the results, you have to look at what actually they mean by the liberal and restrictive kind of protocol. So everything is protocol dependent. So since we're in a study organized by plastic, so one of the things that people think about, we shouldn't be giving vasopressor in plastic surgery. Nanti the free flap will fail. So we are worried that the flap is going to get necrotic because we are giving patients vasopressors. So this is a study, a retrospective one, looking into fluid management and vasopressor therapy and outcomes on flaps. And they found that a balanced fluid administration regime compared to a liberal one caused lesser complications in flap outcomes, and there were zero negative outcomes as related to vasopressor therapy, which means that giving vasopressor in flap surgery is still safe, especially if you do it in a reasonable manner. I think this goes back to the fact that you need to understand that when patients undergo anesthesia, there are many reasons for hypotension, and hypotension is not solely the cause of hypovolemia, and it could be other factors. And sometimes those other factors are better mediated by vasopressors as compared to fluids. So, another scenario where you can have fluid imbalance is in the so-called septic or the critically ill patient. And the modern definition of sepsis is just a dysregulated response to infection, very vague. And we need to understand in the septic patient, in the critically ill, hemodynamic changes are extremely variable because you need to know they are dependent on what kind of illness they are experiencing. Do they have any concomitant cardiac problems? And what is the exact change in the fluid status and vasomotor tone as well as the permeability? So it's very vague and complex and wide. And it's very difficult to know what to do if you don't know what's actually going on, because you can have a patient that is critically ill, that is in shock, but the reason for the shock can be very different. For example, you can have a patient that is hypovolemic, or you can have a patient that is currently having cardiac tamponade, or you can have a patient that is currently having heart failure, or you can have a patient that is currently experiencing pulmonary embolism. So these are all four scenarios where they are all hypotensive, but the reason why they are hypertensive is not the same, and therefore the management shouldn't be the same. So to understand that, you need to go back to basic medical school. So blood pressure is equivalent to systemic vascular resistance times the cardiac output, and based on that you can have a rough gauge on the various kinds of shock. But if you look here, obstructive shock is not in the picture. Obstructive shock is basically pulmonary embolism or tension pneumothorax. So they are not in this picture. So if you think that fluid management is a big part of obstructive shock, then your patient is probably going to be dead very soon. So people think that fluid overload only concerns the lungs, but actually fluid overload concerns a lot of systems. For example, like the CNS, in the cardiovascular, even the renal and GI, as well as skin and muscles. So fluid overload is something that is not solely related to fluid overload. So people think that you can give fluids forever because they think that the French Stunning law works in their favor forever. So you give more fluid, so you get more preload, and then you get more preload, and you think that the cardiac output is going to rise until infinity. When actually it's not the case, because in normal physiology, there's a pericardium, and the pericardium is stiff, and eventually if you're gonna give so much of fluid, the right ventricle is going to be dilated and it's going to compress the left ventricle, and therefore the French Starling curve does not work forever. This one may not be so clear, so this is even clearer. Even though this is an example of a patient with chronic thromboembolic pulmonary hypertension, but basically it's to demonstrate the fact that when the right ventricle is overloaded, then it will compress the left ventricle, and once the left ventricle is compressed, then it can't pump any fluid, can't pump blood. Another thing to keep in mind is that when the heart is small, and the heart has to work less to give the same amount of pressure. This is Laplace law. And once the heart is dilated, then it has to work even harder to give the same kind of pressure. So giving fluids forever does not actually bring a positive outcome to the patients. So basically, one needs to understand that people thought that CVP was the aim, but CVP is actually just a back pressure. So because when you talk about perfusion is basically the difference in pressure, and the key is to get a good difference in the pressure, not the back pressure itself. And so in the ICU, people were worried. The issue is trying to find the middle ground of fluid administration, where you don't get hypovolemia, and you take into account the heart, the kidney, as well as the lungs. So the critically ill, there are 4 phases in general as regards to fluid therapy. They are the salvage, the optimization, and then you have the stabilization and de-escalation. So in general, during the first 2 phases, people are a bit more liberal, whereas in the later phases, you need to really think hard of when you should give fluids, because fluids are drugs. So people think that everybody understands that if you give too little fluids, patients die. But what about if you give patients too much fluids? So this is quite a long time ago study, not too long. So in African children, 40 mils versus 10 mils in African children with sepsis, and they found that the children giving 40 mils, they all die much earlier, especially as regards to early mortality. And then there's the ARSNet group study looking into the fluid management in ARDS patients, and they found that in the restrictive group, there was no change in the mortality. However, the restricted group had earlier discharge from ICU, and they had earlier liberation from the ventilator. So liberal is generally good. Restrictive is generally good. So this is a study even much more in the past, in 2008, the SOAP study. So this is looking at fluid balance as well as the incidence of AKI, and they found that having a liberal fluid balance is associated with AKI, and AKI matters because AKI is the one that kills. So whether ICU mortality, ICU stay, hospital stay, they are all affected by the presence of AKI, and the presence of AKI is influenced by the fluid balance. So this is a systematic review 2014 by Melbrain. So this one is looking at the fluid balance. This one looking at the kind of fluid regime, and having a negative fluid balance and a restrictive fluid regimen improves outcomes in patients. So like I mentioned, people thought that CVP is the target, but probably it's more important to understand that CVP is just a back pressure, and targeting high CVP probably kills. So this is a study just looking at CVP alone, and the higher the CVP, the higher the risk of AKI. So targeting CVP is probably counterintuitive. This is actually basic neuro anesthesia, neurocritically ill. They all say you shouldn't have a high CVP, but the rest of medicine find it hard to believe that targeting a low CVP is probably the way to go. So not all studies support restrictive fluids. Of course, there are some studies that contradict, but again, you have to look at the study protocol. So in the classic trial, they found that there was no difference in the outcomes. But in this study, most of the septic patients were actually GIT. And I think if you have a patient that's vomiting and having diarrhea, it sounds prudent to give the patient fluids. So again, you have to look at the study in specific. So what about the kind of fluids and the kind of crystalloids, normal saline versus balance? Do they make a difference? So physiological studies in volunteers have shown that renal blood flow is reduced in patients given normal saline. But do they translate to the actual patients? So Yunus, who's a Malaysian, with the collaborators in Australia, did a trial in the ICUs, and they found that patients given normal saline had more renal-related harms. However, the mortality risk was the same. And then the split trial, there was no difference in outcomes. But then again, there's a lot of bias in the sense that clinicians could identify which ones were given normal saline, which ones were given other fluids. All they had to do was look at the chloride. So there could be bias in the management in that sense. And then the SALT ED trial, they found that normal saline is associated with worse renal outcomes in patients, but similar mortality. Then a similar study, SMART, instead of ED in the ICU, they found overall same outcomes. But when you did secondary analysis of this study, when you look at patients, looking at the difference in the fluid administration in the ED itself, so patients who were given exclusively balanced solutions had better mortality outcomes as compared to those given normal saline. And then the basic study, there was no difference, but this study had a lot of less ill patients, so less ill patients probably doesn't make a difference. But this study confirms that normal saline should be the default in the traumatic brain injury patient. Whereas in the PLUS study, no difference but large amounts of fluid contaminations and protocol deviations. So difficult to interpret. So Hammond did a systemic review in 2022 and they found that there is a difference in mortality when it comes to normal saline versus balanced solutions. The difference is there, very small, 211 versus 223 per 1,000 patients. So there's a small difference in the mortality, but it's there. And there's differences in the need for renal replacement therapy, ventilator 3 days, as well as vasopressor 3 days. But of course, these are all studies done in the ICU setting. So, and the difference even here is generally small. So because of that, the takeaway is for the less ill patients, normal saline probably does not make a difference. Normal saline is low cost, the familiarity is good, but for the critically ill, normal saline is probably best avoided because every hit counts in the critically ill. And however, when you talk about the neurotrauma patient, normal saline is best. Sterofundin is isosmotic as an alternative, but it's compared to normal saline, it's much more expensive, but not much more expensive compared to some other fluids that I'll talk about later. And keep in mind that most balanced solutions contain calcium and are not compatible with blood products. So you need to prime them in order to reduce the risk of microthrombosis. So what about albumin? So albumin has glycocalyx preserving qualities in the lab. In actual clinical studies, they do give good outcomes in cirrhotic patients in specific indications like SDP, hepatorenal syndrome, and when you do large volume paracentesis. But what about critically ill patients? Overall, there's no difference except in the patients. In the SAFE study, they found no difference except in the patient with TBI. In the patient with TBI, you give albumin, they die. And this is probably because 4% albumin is isoosmotic. And that's probably the reason why they die, because of the worsening cerebral edema. So in the Albius trial, looking at albumin in the ICU, they found no difference in general septic patients, but looking at the subset of septic shock, there is benefit. So basically, there's more research. So you might think, why don't we give albumin to everybody? You shouldn't give albumin to everybody because albumin is expensive. So like I said before, sterofundin is more expensive than Hartmann, but sterofundin compared to albumin is nothing. It's nothing. So anything you do in medicine, not only you have to look at the harm and benefit ratio, you also have to look at the cost benefit ratio. And albumin, it's expensive. So what about synthetic colloids? People love to give Gela. We used to have We used to have Bolivan back in the day, but now we no longer have it. So in the past, people think that if you want to replace fluids, there should be a 3:1 crystalloid to colloid ratio. However, new practical studies shown that the ratio is probably much closer, so you don't have to give so much of crystalloids. But one of the things that people find is that AKI is a very well-known risk in hydroxyethyl starch (HES), especially in the critically ill, and therefore that led to the withdrawal of all the HES products in the world. However, AKI is also a risk with gelatin, and this is probably underappreciated among us Malaysians who love gelatins. And another thing that people forget is that gelatin have a significant anaphylaxis risk. And gelatin doesn't actually act that long anyway. It only acts about 1 or 2 hours at most in terms of plasma expansion, after which it basically acts just like a crystalloid. And just food for thought, gelatins are not available in the American market at all. So why are we so in love with it? So this is a study looking at outcomes, just comparing HES, gelatins versus crystalloids. And they found that HES definitely led to harms, especially in the ICU length of stay, time of ventilator, and the AKI risk. So definitely makes a difference. But it's not just hydroxyethyl starch that causes harm, but it's also the gelatins as well. So gelatins also cause harm, but not as much as hydroxyethyl starch. And when looking at AKI itself, the risk factor for AKI definitely includes hydroxyethyl starch and gelatins. So these are things to keep in mind when giving your fluids for the critically ill. So what about burns? Last topic. Everybody's brain is already burning probably. So what's important is that shock in burns is multifactorial. This so-called concept of burn shock. Lunn and Broderchuk was actually developed all the way back in 1944, and the Putnam formula was in 1968. It's actually nothing much new in terms of burn resuscitation. So everybody knows you need to give a lot of fluids because there's a lot of leaking and everything. But everybody understands that giving a lot of fluids can bring harm to the patients. And if you give so much of fluids such that patient develop abdominal compartment syndrome, if you need to do a laparotomy and leave the bowel open, they find that mortality is probably universal. So people try to think, whether we do monitoring-based fluid therapy, putting the CVL, putting a PA cap, putting whatever, and they found that actually there's no superiority as compared to just using the normal Putnam formula. So it's very difficult. Oliguria can be from under resuscitation, can be from over resuscitation. You give so much of fluids, patient develop abdominal compartment, they also get oliguria as well. So people think about maybe we should have some permissive hypovolemia. Allow the volume to be a bit low as long as they are generally functioning. But basically, there's nothing much that's concrete in terms of the management of burns patients. And therefore, you just have to have an individualized, cost-conscious management. So people try to think whether you should give hypotonic solutions in order to limit your crystalloids. There's nothing conclusive at the moment, but there is promising evidence that maybe that should be the way in the future. Give crystalloid, and then if you give a lot more crystalloid, maybe you should give hypotonic solutions. However, in burns, it's generally the accepted standard that balanced solutions are the way. So what about colloids? Nothing much in terms of synthetic colloids because everybody looked at the critically ill studies and they decide not to use synthetic colloids. But what about albumin? Albumin does show some benefit in terms of abdominal compartment and mortality, but basically we need more studies to justify the use, especially as you've seen the cost. Questions?
Questions. Number one, what does without prejudice mean? You're using the term without prejudice.
Okay, so what I mean without prejudice is that regardless of whether the patient has heart failure or whether the patient is a renal patient, if the patient has an open body cavity, I would still give about 1 pint per hour, just to account for the evaporative losses.
Yeah, not judicious bleeds, maksudnya tak just for the
Okay, so when you talk about perioperative in patients, for example, in heart failure, so the question just now was about the use of my sentence of 1 pint per hour without prejudice in laparotomies. So what I mean by that is that regardless of whether the patient is a renal patient, whether the patient is a cardiac patient, I will still give that same amount because there is the losses, estimated losses from the body cavity from evaporation. So you still have to replace that. So if you become too restrictive, then you may make the patient so-called under volume lah, because of that. So if the patient is but of course in CCI patients, then they may need some inotropic support so that they can tolerate the fluids given.
Why does reconstructive not permeate the intracellular fluid component? Just now, it's one slide.
Okay, let me show. Okay, so when you give fluids, where they go basically depends, in general, where the fluid goes depends on the sodium content. Okay, so if you give patients that 5% dextrose, which does not contain sodium, it's basically free water because it goes into the cells. Then what you get left is just free water. Free water will go everywhere, intracellular, interstitial, and plasma. But if you give patients crystalloids, because they contain sodium, and sodium is the main extracellular cation. So it will remain in the extracellular compartment. So, but of course, it will be equally distributed in the plasma as well as the interstitial compartment.
Okay, then one of your last slides was saying in burn resuscitation that oliguria is a marker of both under and over resuscitation. I think because traditionally we were taught that the kidney is sensitive to what we call like hypoperfusion. So that's why we put in the CBD to gauge the fluid status. So how come, like, what's happening there when you say that over resuscitation also leads to oliguria?
Okay, so that's why I mentioned just now the concept of ACS, abdominal compartment syndrome. So especially if you have major burns that involve the torso, so they can get eschar over the torso, and then you give a lot of crystalloids, they develop interstitial edema. So you have problem with the eschar, which is hard, and then you have a problem with edema. And you need to remember, edema is not just something on the skin. Edema also occurs inside the body cavity. That's why just now you give a lot of fluid, even in laparotomy, they get delayed bowel recovery because the bowel gets edematous. So you give a lot of fluid in burns patients. If you give too much of fluids, then everything in the abdominal compartment becomes edematous and becomes tight. So when it becomes tight and the abdominal compartment pressure exceeds the CVP, then your perfusion pressure is no longer dependent on the MAP versus CVP, but it's dependent on the MAP versus the abdominal compartment pressure, and therefore that will lead to reduced perfusion pressure, and that leads to oliguria.
Just now, we spoke about negative fluids, negative balance, and also mortality, right? There's a study you showed. That study, what's the age group? Is it all adult population or any pediatric population, adolescent involved in that? Just want to know.
That was an adult study.
Purely
There was a surgical ICU study, so it's purely adult.